First of all, I want to say thanks, Mark, and thank you for being here. I was at dinner last night and I was talking and I just said something to the effect that, I am so glad that we had those public hearings 3 years ago. And I don't know if any of you participated in those, but I got to tell you, the state of Florida was getting hammered by its general lack of response to the opioid crisis in the state of Florida. I mean, it was really, frankly, from where we sat in our shop, it was very difficult. The major response we had, frankly, was Amanda driving around the state with boxes full of Narcan, and doing Narcan distribution. That, for the most part, was the opioid response in Florida. It was totally, for those of us who have, who do autopsies every day on their performance and where you are, it was pretty embarrassing. But I got to tell you, one of the things that occurred during those public hearings was a refinement and an understanding of the tragedy associated with this opioid epidemic and the number of people who have been touched, the number of husbands, mothers, fathers, children who were lost to the opioid epidemic, and basically, and how rightfully so, how pissed off people were about the absence of an assertive, helpful response. As a result of that, by the time we had the last public hearing, we were in the car on the way home and the governor issues an executive order. In my personal opinion, that executive order was a year too late, but it did basically provide the incentive to basically marshal the forces and trying to be responsive to those communities that we've just been through, plus those who had summits, who had opioid summits, who had working with people who were living with the consequences of the opioid epidemic on a daily basis. We were fortunate that the feds came up with funding the STR grant several years ago. I have to tell you that I think that based upon the response of, in a sense, the department's response, the association's response, the industry's response, and your response, we have basically started to make inroads into the consequences of this out throughout the state. We're not done, and there's a lot of lessons to be learned, but I want to express my appreciation to you all because basically you're the people that are laying hands on people. We're not. You're the implementing the policy, good, bad, or indifferent, that is established by the feds for the expenditure of this money. Over the course of the last 2 months, I think Florida has been recognized. You're not going to read about it, but I mean, it's one of these things where, because of the ability of Florida to respond, to organize, to develop the types of services, capacity, and capability, to implement medication-assisted treatment, pretty much statewide, which frankly represented a huge culture shift in the state, and is still going on. The feds basically had $26 million additional dollars that they said, "Can you use it? We'd like for you to have it." And it was like, "Yeah, we can do this." So, and I think basically it was that attitude, I think, of can do, based upon the performance of the people in the field, based upon the impacts the money it had to date. And I'll be real frank with you. To a large extent, it was based upon the work that a lot of these people doing in the very front of the room did. I mean, basically the credibility of this state lived and died with the ability of the department to basically say, we can make this happen. And in that regard, I got to give a lot of recognition to Uta and her team. I mean, because it's like, this is as close to rocket science as anything we've ever done. Cultural change, policy change, implementing, in a sense, one of the things that the department does that we do very well is we implement bad public policy extremely well. We got that. And I'm not suggesting that there's anything about this that is bad public policy. It's all great public policy. But the infrastructure required in order to document the services to do this work are just really, it's really tough. And that's for a large extent what we're here to talk about today. There's no such thing as free money, and it is all based upon a lot of excruciating effort on your part and our part to basically document what it is we're doing. So in that regard, I want to say thank you for being here. Thanks for participating with us on making things better and improve the lives of the people who we touch. And I'm going to turn it over to Uta. She's next, unless you want to do this. Okay. Uta is Uta is my muse. That's not quite, it's like in the scheme of things, that's not necessarily consistent with a lot of people's vision of Uta being John's muse, but she is. She is one of the smartest, most committed, passionate people I've ever worked with, the best public policy mind of anybody I've ever worked with, and is a hard driver and is passionate about this work. She's assembled an extremely capable and competent team of people to do this work, and frankly, if it hadn't have been for this level of effort on the part of the state of Florida, we'd be sitting here with $50 million instead of 76 and ultimately 90 plus. So with that, I want to introduce Uta and say thanks to y'all for coming and for her for being able to pull this stuff together. Thank you.
Thanks, everyone. And welcome, and let me just echo thank you for being here. I did not expect a room this big, so it's exciting that a few years in, we can still get people to the table. I want to echo what both Mark and John have said. We've come such a long way, and I'm just so grateful that you all are at the table and that you're continuing to do the work. And I think once I get into the numbers, you'll see, when you look at the, I know when you're in it every day, I remember being a provider, it just seems overwhelming. And in the roles that you have, almost all the bad cases come to you, right? So all you're ever doing is staffing the things that aren't going well. And I think once in a while you need a reminder that actually you're making a huge impact. So just to go over the funding one more time, we get about close to $110 million in substance abuse block grant a year. That's what you can use pretty much for the entire service array. We have our Partnership for Success grant, which is primarily primary prevention. However, we are also using it for naloxone training and distribution efforts. We can't purchase Narcan with it, but we can pay for the training with that. Then ending in a couple of days is our STR grant. That was almost $28 million. And our SOAR grant started back in September. So it's hugely complicated to keep those two straight. I'm sure you're having just a lovely time figuring out which individual served your billing to what grant. So that'll be over soon. Most of you expended all of the STR funds, so there's only 2 regions that had no cost extensions. And just to think about that, I remember when we first got the $27 million, we were all like, that's a huge influx of money, right? How do we spend that? The first year, there were states that didn't even start spending 7 to 8 months into the year. Florida, we really knocked it out of the park in terms of getting the money out and you guys implementing it into your service array immediately. When you think about that, $27.7 million, our no cost extension was less than $700,000. So, and most of that was actually in admin dollars, in staffing dollars. So we certainly did the most with the funds that we had. So the next year is going to be, again, a little bit complicated. What basically happened is the STR grant was not reauthorized in federal law. The SOAR grant was authorized, but the STR funds were authorized. So what SAMHSA did is basically add the the STR funds that were authorized into the SOAR program. So we just received notice of award that we will get an additional $26 million. And basically what we will do with that is what we do with all the rest. It will be a little bit more targeted than the original $50 million that came with the SOAR grant. One of the issues that we continue to see is continual removals in our child welfare system due to opioid use disorders. So we will target a portion of this funding to MAT specifically for caretakers and parents in the child welfare system with an opioid use disorder. So whether that's, you'll be talking with your MEs about that. It will be, the MEs will be working together with their local CBCs. We're putting the data together right now to overlay our high-risk areas in terms of overdoses with removals based on a substance use disorder, and we'll kind of hotspot that, get that out to the MEs, and they'll be working together with their CBCs to work on a plan on how referrals are going to work, how communication's going to work. So we'll target that population a little more, and hopefully we'll see an impact on removals. The second targeted funds will be, we've been talking a lot with our emergency room physicians and providers, and basically, we opened the SOAR money up to do more bridge projects. But what's happening is providers are already, they filled up their capacity. So basically, even with the additional SOAR funds, we were already at capacity for them not to add any more individuals on buprenorphine, whether that's brick and mortar, they just don't have the room to do it, whether it's staffing. So 10 million of the 26 will be dedicated to hospital bridge projects that will cover both the peers in the emergency rooms as well as the buprenorphine capacity that needs to be added to do the maintenance treatment ongoing. And then the rest will go into the regular MAT bucket, just to give you more capacity for anyone coming through the door. That was the slide I just talked about, broken up with the money. And we're also adding more behavioral health consultants to our CPI units to recognize signs and symptoms of substance use disorder and hopefully have a much quicker referral out of the CPI world before it gets to the CBCs. All right, the goals for SOAR continue to be, number one, reduce opioid death. And I think that's going to be something we'll talk a little bit more about when we talk about retention and engagement into treatment. If we look at that as our number one goals, are our practices supporting that goal? Secondly, to prevent prescription opioid misuse among young people, those are the prevention dollars that are going into the school-based programs, then increase access to medication-assisted treatment, and increase the number of people trained in MAT and recovery support services. And I'll know Wes will talk a little bit later with you all about his efforts on recovery-oriented systems of care, how we're increasing our peer force. So, and I think that's what's been most exciting for me in this transformation. I mean, there are many providers here who've done MAT for a long time, but there's also a good amount of providers who had a lot of convincing to do with their boards that MAT is an evidence-based practice and the standard of care for opioid use disorder. So to see the increases not only in MAT and the prescribers we have, but also the increases in our peer workforce. We're seeing more and more peers getting certified and being hired into meaningful roles. And Wes will talk a little bit about where our strengths are, where we still have some opportunities to grow. And we'll also talk about some of the other recovery supports that we're trying to bring into the state, including Oxford houses, recovery community organizations, and how we hope that you all as providers of treatment really build good, solid partnerships with those recovery communities, because they can really, really, really assist you in getting people meaningful activities within their recovery post-treatment that can be there for a lifetime for them. Again, our approach is medication-assisted treatment as the standard of care for opioid use disorder. The hospital bridge programs continue to be a priority for us. It's an amazing intercept point for you all to reach individuals who may never come to your doors, but that's an opportunity to engage. It's an opportunity to induce and then have a warm handoff into maintenance treatment. Again, those recovery opportunities, we're investing a good amount of infrastructure in terms of getting Oxford houses throughout the state. By the end of the grant, we should have a minimum of 60. That's not the end. As you all know, the way the Oxford House model goes, they work on kind of a rotating fund, which means they set up houses and then those startup costs get paid back, and they completely run on their own, meaning individuals who live in Oxford houses are required to work, they're required to pay their own rent. It's very, very reasonable. We just had a call with Oxford House. They've opened 5 so far, and even the ones that I've opened in Palm Beach, which you all know is a very expensive market in terms of rental. Even there, in their men's house, the rent is $150 a week. So and that includes everything. That's water, electric, rent, everything. So we're very excited about that. And then also working with several of our peer-led organizations throughout the state to become certified recovery community organization, or accredited, I should say. So again, trying to be very comprehensive in the approach, from prevention all the way to lifelong recovery. And this time around, the STR grant really focused on training for child welfare staff and the judiciary, and now we want to also spill over after doing lots of needs assessments and talking to providers about the organizations that they're still having some difficulty with in terms of them understanding medication-assisted treatment. We'll continue to talk with our child welfare and justice partners, but we also want to include corrections, jails, and also Medicaid managed care plans at some point. Just to kind of give you the latest trends in terms of opioid-caused death. Keep in mind, this is not just overdoses. If you're looking at the numbers saying, wait, that doesn't match, this is all opioid-caused deaths. So, except I think we took out homicides, the one thing, yeah. So you see that huge spike from 2015 to 2016. That was the biggest. That was a 55% increase. And that is largely due to the introduction of fentanyl and fentanyl analogs. I know that the number still increased from 2016 to 2017, but I think the hopeful part of this data is that, you know, from 15 to 16, you saw a 55% increase, and then from 16 to 17, it's 9%. So to go from 55 to 9 definitely means it's starting to trend down, but still have lots of work to do, and I know that we're waiting with bated breath for the medical examiner report, which should be out hopefully April or May. We never know, but it's always, for the epidemiologists in the room, it's a happy day. Yeah, they seem to really enjoy that stuff. So to celebrate the things that we've done so far, okay? From STR grant expenditure, so this doesn't even include all the folks that you served with block grant dollars and other funds. We served over 13,000 people with the STR grant. Predominantly methadone was used, over 4,500 are in methadone maintenance treatment, 3,500 in buprenorphine, and 946 served with long-acting naltrexone. Amanda has recruited well over 80 entities to help distribute over 35 naloxone kits. We've purchased over 44,000. And then using the Botvin Life Skills Training courses, we've trained over 3,000 middle and high school students in that curricular. Give you an idea in terms of the growth in capacity over the last couple of years. Pre-STR, there were 65 data waiver physicians in our network, and we've seen a 150% increase in that. And we now have over 163 data waivered physicians in our network. So that's pretty incredible. In terms of DCF-funded Vivitrol providers, we've gone from 11 to 46. So in terms of building capacity, that has certainly been successful. Obviously, as I look away, we have not been able to open more methadone clinics, but we've certainly increased capacity at those that are. So maybe one day we'll have a rule and a way to do this. But anyway, not here to talk about that. Again, in terms of our outcomes, we'll talk a little bit about some of the data challenges. For the first 18 months of STR, we got pretty decent data. I think there were maybe 2 agencies that were left out because the data never kind of made sense. But what we did learn is that 180 days in treatment seems to be a really good number. That's where we're seeing kind of like best outcomes. If you look at non-fatal overdoses, they drop by 94% as compared to the first 30 days in treatment. Stable housing goes from 84 to 95%. Employment goes from 21 to 53%. And in that time period, we've had over 2,500 overdose reversals reported. I think that's obviously hugely underreported because it's voluntary. I'm amazed that we even have that many reported. So what we know is that it's working, right? We know that treatment works. If we can engage folks, if we can retain in treatment, lives are getting better, and that's the goal. So I want to start off by saying that and honoring all the work that the people have done in this room. And I know John had some really kind words, so now I need to brag on him a little bit. I don't even know what I'm going to do when he leaves. I'll probably have to follow because nobody else will let me be as crazy as John does. I can go in and have my temper tantrums, and he just laughs at me, and that works really well for both of us. And, you know, he's been the leader in this, and he's basically the guy that lets you make it happen, right? He's the guy that when you go to him and say, this is the rule, it's stupid, he will go find somebody that helps you break it legally. So take this opportunity to say thank you to you, and I don't even know what we're gonna do.
Our motto in the program office is no felonies.
That's basically, John's answer to me on everything is, well, nobody's gonna come and arrest you. So, although I'm not sure about that. Here are some of the challenges that we're seeing, and we'll talk about data a lot, and I know spreadsheets are a pain in the butt. I get it. But I will tell you this, for the 18-month that we had good data, having been able to send that to the legislature, having been able to send that to SAMHSA has made a huge difference. And I know that you guys don't see this on an everyday level, but I'll give you an example. The SOAR grant funding is for 2 years, right? So we know we have our funds through 2020. However, the program is actually authorized for longer. So if Congress makes a decision to continue to fund it, they have that opportunity to do so because the program is already authorized. SAMHSA, I have sent this 18-month data that I just showed you in terms of all the people served to SAMHSA, to NASADAT, which is the National Association for Substance Use Programs. They're using all of our data to make the point that this is working. If we don't have good data, we will not be able to show that. I'm also concerned about the cliff. You know, as you all know, we got a $16 million appropriation 1 year ago, and it was because we had data. If we can show that our efforts work, that is probably the only way we're going to find ways to continue this funding. So I know it's a pain, and we'll talk about the GIPRA later. But we're going to need to have that data to make our point. I want to make it really clear, too, because I'm not sure if this message has gotten out. As I understand that this is all an extra burden, and there has to be somebody that, does the assessment, and then somebody has to type it all in. Know that you can use SOAR funds to hire a data person to enter this data so that your clinicians don't have to do it. You don't have to have a provider off of the, doing this. You can hire somebody that your clinician bills for the assessment, hands the GIPRA over to a data entry person who does nothing but tip it in. So believe me, all the states, we have all bonded together and tried to, address this with SAMHSA as a whole. And I have witnesses who were on the call with me from the Assistant Secretary of SAMHSA. It's absolutely, the GIPRA is not going away if they ever give us one, which they will. And it is required for every service that is funded under STR. SOAR. So there is, I keep getting emails, can we please be exempt from the GIPRA? Can we not do it with this population? And believe me, we have sent all the concerns on to SAMHSA, and the answer is just simply no. If you are going to expend SOAR dollars, you have to do the GIPRA. So if we can later, as we discuss data, I'd like to have a discussion of how do we make it happen, because it's not an option. So we need to move that discussion from I know it's hard, I know it sucks, to how are we going to get it done? And what are some options that we can help you to make sure you can get it done, okay? All righty. Also, just the data that's going into FASMs. This is going to be a little bit problematic, so I'm hoping that you all can go back to your data folks and kind of take a look at this. But almost a tenth of the individuals served, for example, in STR, do not have an opioid disorder or an opioid as primary, secondary, tertiary. Literally, there's no opioid anywhere in the record. So that's problematic. So we need to make sure that and for the MEs that are in the room, to please start looking at that data too for that particular OCA. 40% did not have an MAT modifier, which means I know that that's not accurate, okay? I know that we do not have 40% of the folks served in STR that are not getting some kind of medication. I think it's a data issue. I think people are just not putting the modifier in. We have lots of discrepancies between the spreadsheet and the data that's in FASMs. You'll see when Stephanie comes up a little later and shows you the data. That'll be the data that comes out of FASMs. You'll see a total shift. The discharges reported on the spreadsheet are completely different than what's in FASMs. We have a few people who are zombies. They're dead in one system, they're alive in another. So we're calling those the zombies that are walking dead among us. Just as a technical note, as Stephanie does her data, keep in mind that right now we're not very confident that that is in any way statistically sound. So it is what's in the system, so we're going to show it to you. But I think this is one of the areas that we have some work to do in, because we need to be confident in the data. That's what's going to get us, that's what we need to show to be able to continue to secure our funding. And that's it. Any questions? They could use STR funds to contract with that provider. They've made a decision for some reason not to. I've actually asked that question why they're not. But that is, I think, a really good question for you as the regional staff to discuss with the managing entity, why they have not yet contracted, because we sent out memo quite a while ago, especially for those regions that do not have a public methadone provider that are already under contract with the managing entity, such as South Florida, where you have 3 methadone clinics that are all private.
If you look,
they can contract.
If you looked at a map, that South Florida corridor is not what you would have, what you call a community methadone provider. Also in Ocala and in Jacksonville, they're using a, what would you call a private for-profit methadone provider, but they're contracting with them in those areas, but they haven't in that South Florida corridor.
But it is not prohibited, right?
No, no, the managing entity can absolutely contract with those providers. So it might be, as you're seeing folks who, you know, may be a good candidate for methadone, you know, as you guys are going in with CPIs or whatever, I think that's a really important conversation to have with that managing entity. You can do services dollars because it's going to the provider and it's part of the provider cost. Well, again, if you all are putting the modifier, but 40% aren't using the modifier. So if we have consistent data in FASMs where everybody's using the modifier for each person served in terms of what medication they're on, then we could. So if we can improve that, if we can get good data in, then yes, then we could do pretty much everything by substance. We can break out methadone from bube, from mono to, I mean, yeah, we can break it by all the modifiers. But we just don't have consistent modifiers, so if I don't know what 40% of the population is taking, then it makes it not so useful.